Hello, I'm Dick Moberg. I'm your host for today's presentation. And welcome to this edition of Brain Matters. And thanks so much for joining us today from wherever you are. We realize most of you listening are in the healthcare field. And as I said last time, on behalf of my company and our employees, I want to thank you for what you're doing. Our future is definitely in your hands. So our featured speakers today are Dr. Brandon Westover and Dr. Sahar Safar from Harvard Medical School and Mass General Hospital in Boston. They'll be talking about big data and AI in EEG. And by the number of registrants we had for this one, it's definitely a hot topic. We're doing things differently this time, and we'll be going live to Boston for the main presentation rather than playing a recording. We'll then be going directly into the Q&A period, so please type in your questions during the talk. And before we get to our speakers, here are two quick reminders. I want to remind you about our newsletter, the Neuroscience Monitor, which will keep you up to date in neuromonitoring. You and your colleagues can sign up anytime on our website. We've gotten some great feedback on the newsletter, and I want to thank you for that. And please, if you have an event or news item related to neuromonitoring and neurocritical care, send it to us. And finally, I'd like to tell you about my podcast, Dick Moberg's Neural Network. I've been in this field for 40 years and thought it would be interesting to tell the stories of those who helped shape the field of neurocritical care. One podcast from late last year was how John Gottman got started in automated seizure detection. It provides a nice background for today's presentation, so take a listen. And a final reminder to type in your questions. We'll now go to Drs. Westover and Safar in Boston. And let's see how this works, our first live webinar.
Thanks for the introduction, and forgive any errors that occur along the way. We're doing this the first time. So our topic is about automating the analysis of EEG, and I thought I'd just start with an old picture from 1920. This is from a movie, or actually, sorry, a play, Rossum's Universal Robots, which is the first time I think that the word robot was introduced into English, if I understand correctly. And so this was the way people thought the future might look when AI was a reality, right? These robots in the factory initially worked for the people, and they got tired of it, and so they exterminated everyone and just took over. So hopefully nobody has that fear, but there may be some anxieties about what it will look like when computers can read EEGs better than us. And so I think Sahar and I will talk about what the prospects of that happening are, and then if anyone wants to talk about the pros and cons of that, that would be a fun topic as well. So just to kind of get into the topic of we're not just talking about seizures, but also what we call the Ictal-Interictal-Injury-Continuum, or that's a term coined, I think, by Larry Hirsch and some colleagues. And so just to introduce that idea, which many of you are probably familiar with, I just wanted to share a page that I got back in 2011 when I was still a trainee. I was a fellow helping read EEGs for patients who were being cared for in the ICU. And this is my colleague, Terry Coomer, and he wrote, Dr. Stinko, any thoughts on the LTM, this continuous EEG monitoring for a certain patient in the neuro ICU? Could it be PLEDS? And so there's a kind of a inside joke here, or a kind of frustration that Terry's expressing with his sarcasm about patterns that I'm showing you here. Right, so up in the upper left, this is a normal EEG for reference, and in the lower right, there's kind of the extreme opposite, which is a patient having non-convulsive status epilepticus, continual seizure activity, and it's pretty clear that this is really bad, and this is fine. But there's these other intermediate patterns that are often vexing, right? Like they were vexing to Terry, called generalized periodic discharges, where there's discharges at pretty regular intervals on kind of synchronized in the left and the right side of the brain. And these are kind of like seizures, and people are often impaired when they have them, or can be comatose, but they're not quite, they don't really meet criteria for calling them seizures. We have these other patterns like lateralized periodic discharges, where the discharges are on just one side, lateralized rhythmic delta activity, or LRDA, and then these bilateral independent periodic discharges. So these are kind of collectively what we usually call the Ictal-Interictal injury continuum patterns. And so what we want to talk about is how to kind of detect these and what they mean. So I'll let Sahar take over from here.
Thank you, Brandon. So here is just, a review of common disease scenarios that we typically see these patterns in. So as you can imagine, lateralized patterns, which is both LPDs as well as LERDA, tend to be seen more commonly in patients who have a structural brain injury, such as a stroke, TBI, hemorrhage, infections, tumors, while the more generalized patterns, including GPDs and GERDA, are seen more often in patients who have a diffuse process, such as hypoxic ischemic encephalopathy, sepsis, metabolic derangements. However, that's not a hard and fast rule, and we can see lateralized patterns in patients with a diffuse injury process, and vice versa, more generalized patterns in an acute structural brain injury. But the real question, as Brandon mentioned, was what is, are these patterns ictal, interictal? Do they result in secondary brain injury? And what is their association with outcomes? And ultimately, whether they should be treated or not. So next, I'll be reviewing sort of some of the data that we have about relationship of these patterns with seizures and secondary brain injury. So this is one of the largest studies published by the Critical Care EEG Monitoring Research Consortium, showing which patterns are associated with the greatest risk for seizure. And as you can see here, LPDs, LERDA, GPDs all have a high association with seizures, whereas GERDA, or generalized rhythmic delta activity, we're starting to see more and more is less likely to be associated with seizures, as well as with poor outcomes. And the other thing about interesting finding was that these patterns have a frequency-dependent association with seizures. So the higher the frequency, the greater the association with seizures. And then in addition, if they have plus features, which include superimposed fast activity or superimposed sharp activity in patients with LERDA, that also increases the association with seizures. So next, I'm going to talk about the data that we have on the association of these patterns with secondary brain injury. And again, there are small cohorts or studies that have looked at this. This is a study done by Aaron Struck, who looked at PET correlates with IIC patterns. And on the right here, you can see that acute seizures, so generalized convulsive, non-convulsive status epilepticus, are associated with PET hypermetabolism. Similar to that, patients that had GPDs, LPDs, and spike and wave activity also had PET hypermetabolism, suggesting or showing at least an association with increased metabolism and potentially secondary brain injury. Other work includes this study done by the Columbia group, where they looked at patients with aneurysmal subarachnoid hemorrhage and the association of periodic discharges on deep intracranial EEG recordings and association with brain tissue oxygenation. And here at time 0 is when high frequency, which is more than 1.5 hertz, periodic discharges start. And at that time point, there is a significant decrease in brain tissue oxygenation, again suggesting some, at least an association. This was a small cohort, so we can't necessarily extrapolate to causality, but there is definitely an association with increased brain tissue oxygenation with the onset of high frequency periodic discharges. Another study done by Paul Westphal, again, looked at a similar association with metabolic crisis, but this was specifically in patients with traumatic brain injury. And you can see here again, during periods where with periodic discharges, there was a drop in brain glucose as well as a rise in brain lactate pyruvate ratios. Whereas in the non-ictal period, there was an improvement in brain glucose and a drop in the lactate pyruvate ratio, again showing an association with metabolic crises and potentially secondary brain injury. So, we've shown that these patterns are associated with increased risk for seizures, they're associated with secondary brain injury. The next question, of course, is what about the association with outcomes? And this was a study, again, looking at subarachnoid hemorrhage patients done by the Columbia group. On the x-axis here, you see the number of hours spent in seizures, and this is seizures on SCAB EEG recording. And on the y-axis is the probability of a poor outcome. And as you can see, as the time spent in seizures increases, there is a rise or an increase in the probability of poor outcomes. we tried to, we looked at, similarly, we looked not only at seizures, but also at all the other IIC patterns that we have talked about. And again, found on the x-axis here is the maximum daily burden. We found that as the maximum daily burden of these IIC patterns increased, there was an increasing probability of poor outcomes, almost an 40% increase. And then the outcome here is 3-month Glasgow outcome score. Finally, we did the same thing with patients with ischemic stroke and demonstrated a similar finding where an increase in the maximum daily burden of IIC patterns was associated with an increasing probability of poor outcomes. In this case, we looked at discharge modified Rankin scale in patients with severe acute ischemic stroke. So, what we're going to go over right now is sort of the next big project that we've worked on, which is trying to determine the independent impact or whether these patterns independently predict poor outcomes in critically ill patients. And as you know, and this diagram shows, in these patients, outcome is not only determined, by the type and severity of their brain injury, but also the severity, how critically ill they are, whether they have other systemic comorbidities, the type and aggressiveness of all the treatments and interventions they get. They're very complex relationships that we're trying to tease through over here. And what we try to do is, as I mentioned, determine what the independent association of these patterns is with neurologic outcomes. And what we did was we essentially we looked at a large database of 2,000 critically ill patients. These were all adult patients over the age of 18 years who underwent continuous EEG monitoring. And what I'll go through next is the clinical data, and then Brandon will take over after me to talk more about the EEG data extraction and annotation as well. So as I mentioned, this is data for 2,000 critically ill patients. Here we're just showing the burn down chart. We collected all their clinical data over a period of 1 year, and we actually had, as you can see, 2 rounds of data collection to ensure that we obtain accurate data for these patients. And then there, just a description of this database. The median age of these patients was 62 years. So, they were mostly middle-aged adults, and about 50% of the patients were female. They all had at least about 2 to 3 days, a median of 50 hours of continuous EEG recording that we looked at. And we looked at several disease severity scores, including their admission GCS. We looked not only at their initial GCS, where you can see over here the distribution where most patients coming in had either GCS of 3 or 15, but we also looked at the lowest GCS within the first 24 hours of presentation. And again, most of them had the lowest GCS was a GCS of 3. We looked at their Apache 2 score, again, as a marker of disease severity. Here, the median Apache, and this is the physiologic Apache score. Since we were looking at GCS separately, we calculated only the physiologic component of the Apache 2 score. And the median physiologic Apache 2 score was 10. So these were pretty sick, critically ill patients that we looked at in our database. And finally, we looked at not only their discharge, our outcome measure was not only discharge modified Rankin scale, but also their premorbid MRS. You can see about half our patients came in with an MRS of 0, were completely functional and independent. And by the time of discharge, more than half of our patients had an MRS of 4 to 6. And just as a reminder, MRS of 6 is dead. MRS of 5 is severe disability. Those patients are typically bedbound. MRS of 4 is also significant disability. They require most assistance in most activities of daily living and require assistance with walking as well. And then finally, just reviewing their diagnoses. So as I mentioned, this was critically ill patients across our hospitals, so included both neuro as well as non-neurologically critically ill patients. Not surprisingly, the most common neurodiagnosis was seizures or status epilepticus, followed by subarachnoid hemorrhage, intraparenchymal hemorrhage, hypoxic ischemic encephalopathy, and toxic metabolic encephalopathy. TBI was a big cohort as well, but we sort of broke down TBI into subdural hematoma versus other TBI. And the one advantage or the one good thing about this database is that we had at least 200 patients within each of these diagnostic categories that are important. And then we looked at their any associated or any primary systemic diagnoses. About half our patients did not have any major systemic illness or comorbidity. And for those who did have a primary systemic disorder, respiratory failure, cardiac failure, and acute kidney injury were the most common systemic diagnoses in our patients. And you can see up here about 15% of our patients developed shock during their admission. So I'm going to pass this over now to Brandon to talk about the EEG data.
Yeah. So just thinking back to the diagram, so the first part was to, we're trying to estimate this model that allows us to relate, these seizures and IIC, type of patterns and the burden of them to the illness, the treatments, and ultimately to the outcome. So the next thing we had to do was try to annotate data from 2,000 cases, each 24 to or more hours long. And so we kind of initially hoped, although we knew what the answer would be, that maybe somebody had already kind of solved this problem and already had an automated tool that would do that labeling of the data for us. But I think maybe any of you who read EEG probably know that it's not common to just rely on automated solutions. We still do this by eye. And the reason is that although there have been several attempts to kind of make progress on this problem, they've mostly been very small studies. And so as a result, the algorithms that have been developed so far don't really generalize well, and they're not convincing. So here's just some examples from some colleagues that we know well and respect a lot, but this is just a hard task to do. So there's a paper where 29 patients or 0.9 hours of EEG were used to develop a seizure detection algorithm. Here's one with 10 patients. Here's one with 24 patients. So I think for us, we felt like, well, there's so many different types of different patterns that we see, and within each pattern, so many variations on that it's just this is an unsolved problem. And so we set out to try to do this, once and for all, essentially. And so we, as Sahar mentioned, we took data from these 2,000 cases. We also, because we only wanted to do this once, we took additional data so that we could see other kinds of seizures from EMU patients and then from outpatients as well. There's very few seizures in there, but this has a lot of background varieties. And so the goal was to kind of train computer algorithms that would be able to automatically label this data. But first, we have to label some of it, at least, in order to teach the computer what it is supposed to do. And this is hard because this is about 30 terabytes of data, or the way we conventionally read the EEG one screen at a time, this comes out to something like 36 million screens. So how do you do something like that, right? So we used a trick so I want to just explain to you with this picture. So the picture, this is a picture not of anything related to EEG, but this is a whole bunch of little tiny images. And it turns out if you look really close, these are images of handwritten digits. These are used for developing an AI that reads postal codes actually originally. So if I zoom in here, what you can see is that all these little things here are number 7s. These ones are all number 4s. These are number 9s. And so what's actually happened here is that there's a computer algorithm that is able to, without any human help, other than to say, what are the features to use to describe these little images, it's able to group them into clusters. And once they're grouped in this way, you can, as you can imagine, you can very quickly just inspect a small fraction of them. There's no need to look at every single one. And once you're convinced that they are, grouped in a meaningful way, we can kind of just draw a big, boundary around that cluster and say, please assign the label 4 to all of these, or number 9 to all of these. And although it'll be imperfect at the boundaries, this gives you a huge head start in, creating training data for algorithms like we're trying to do, right? So out of 36 million, maybe we only have to label, a tiny fraction of that. And so we've been doing this with EEG. Here's kind of illustrating the proof of principle. So this is a single patient's EEG. I think this is a 72-hour EEG. Each of these little dots here up here in this cluster is corresponds to a 2-second fragment of EEG. That 2-second fragment has had features extracted from it. Those features actually encompass information from surrounding the 2 seconds as well, so that some context is necessary to figure out what it is. But in any case, the features have then been, we've used those features to create this 2D map where, in creating this map, it's called an embedding map, very similar to what we saw with the digits. Things that have similar features end up close together on this map, and ones with different features end up spread apart. And it turns out that when you look, and inspect the dots here, and again, this was created with no human effort, all the things labeled number 1, they look kind of like this. So I'm showing you one example in a spectrogram here, and down here, these turn out to be periodic discharges, either LPDs or GPDs. I'm only showing you 2 channels, so we can't tell, but it's periodic discharges. Number 2, these all turn out to be parts of seizures right here. And then number 3, all these dots turn out to be endings of seizures. And so they're organized by feature space rather than by time in the EEG. We've done this with, let me see if I can make this movie work. So here's a little demo of how we do this for individual cases. So this is created by a very talented postdoctoral fellow, Jing in our group that we work with closely. And so what we're doing is, there's this embedding map up here for this patient's EEG. You can see that they're kind of color-coded, and this is determined in an automated way. And then there's these buttons up here. I'm classifying the different patterns that this thing is showing me as seizures. You can see there's spectrograms here. There's 4 different regions that we're seeing the spectrogram on, so I can see asymmetries between left and right. And then what the program's asking me to do is it's saying, look, I've identified clusters already. Just tell me the label that I should apply to the whole cluster, but based on this center cluster, right? So we're getting a good approximation to the labels that belong to the whole group by looking just at the middle. So, and if you look, here's a timer up here. Here's how long has elapsed. So I think it takes, so 1 minute and 5 seconds. And I've labeled the entire EEG. You can see in red here, these are the things I've labeled as seizures, and blue is all the rest. So this case has mostly seizures in it, and we can kind of inspect them afterward to see if we want to modify anything. And you can see nicely, right, all the seizures have been selected out on this little colored graph. So this is showing, I think, 20 minutes, by the way, down there. All right, so that's on a case-by-case basis, we can do this. And then I have a web application where we put up examples using that are kind of most valuable to have labeled by a large group of colleagues. And we've been really fortunate to work with a group of colleagues in the Critical Care EEG Monitoring Research Consortium. I think we have over 30 people participating in this project, where we're labeling the important samples from these more than from these 30 terabytes of EEG data to kind of cover basically cover the landscape. And at the end of this, we hope to have a detailed map of all the types of seizures and GPDs, LPDs, LRDA, GERDA, and and then in turn a way to automatically label these, because this is training data, right? So we have currently I can't remember which version we're on now, something like number 20 or so, a version of a convolutional neural network that is trained on these data we're creating. This is actually, we're a little bit beyond this now, but this is kind of a recent look at how the performance of our current best model. Remember that the gold standard here really is just how well one expert can agree with another, right? That this is an experience-based. These labels are based on expert experience, and so for seizures, the blue bar shows that experts on average agree with each other something like 45% of the time. Now that's actually not as bad as it sounds, because there's actually some true ambiguity between seizures and LPDs and GPDs. In some cases, the boundary between those is not crisp. So anyway, the red bar shows how well the algorithm currently agrees with the experts. So with seizures, we're not quite there yet. With LPDs, we're not quite there, but we are there with GPDs and LRDA and GERDA, and then pretty close to other. So this is, again, I think in a month or so, we'll probably have this finished, I'm hoping. But this is where we are now. So taking nevertheless, this current model, we scanned it over all the data. So this is a swimmer plot, and we have 2,000 rows in this plot. Each row is one patient, and the colors indicate what's happening with those patients. We've sorted them so that the patients with the highest burden of seizures and IIC patterns float to the top. And I'm going to zoom in to this upper left corner to show you just some examples. So this is this is now this automated detector saying in red that this patient is having seizures. This is a status epilepticus patient. I think orange is GPDs. So, and then yellow is GPDs, orange is LPs. I think blue is GERDA, and then gray means that they're missing data, so maybe they went for a scan or something. So we have this, very rich, set of labeled data at a 2-second resolution now. And so with this, I'll turn back over to Sahar to talk about how we can now use both the clinical data and now this, high resolution set of, high quality labeled data to answer the, end question of how does all this impact the outcome?
Thank you, Brandon. So we developed an outcome prediction model, again, going back to our objective, which was to try and determine the impact of these patterns, how they predict outcomes. And we did multivariate logistic regression using lasso regularization for feature selection. And these were the initial variables that we included. So with regards to, we had EEG variables and then clinical variables. And with regards to the EEG variables, we used 3 formulations of the IIC burden. This included the first 24 hours, so percentage of the first 24 hours occupied by IIC patterns, then the 12-hour window that had the highest burden of these patterns, and then the cumulative burden across the entire duration of recording. Clinical variables included age, gender, their BCS, whether they had mechanical ventilation on admission, whether they had a history of acute brain injury or a history of epilepsy, cardiac arrest or seizure on presentation, and then their admission diagnostic category, and then finally the physiologic Apache 2 score as a marker of disease severity. And these were the features that were selected. Of the EEG variables, it was the burden, the maximum, the 12-hour period, which had the highest burden that was selected, age, GCS, cardiac arrest on presentation, seizure on presentation, if they had a diagnosis of an acute brain injury, and then the Apache 2 score. And then this here, we're reviewing the performance of this model. On the left is the ROC curve, and you can see the area under the curve is approximately 78 or 0.777. And then on the right is the calibration, and our model performed very well with the predicted outcomes matching very closely with the actual proportion of poor outcomes. The poor outcome here was defined as an MRS of 5 to 6 at discharge, so severe disability and death at the time of discharge. And then finally, again, we looked at the modeled probability of poor outcomes, and what we found was on the x-axis here is the 12-hour epoch that has the highest burden. And as you can see, if you go from no IIC patterns to 100% of that 12-hour epoch being occupied by IIC, the probability of poor outcome at discharge increases by about 40%, controlling for all the other factors that, all the other clinical factors that we talked about and have included in this model. So what we found here was that it seems like it's more the intensity. So if you have, a short period of time with, that is completely, which is 100% occupied by these patterns, has a greater association with poor outcomes than, a low percent or a low burden of these patterns that's distributed over a more prolonged period of time.
So I'll just share some thoughts about, where we're going next and kind of what some of this means. So, and I think one really nice outcome is that we, so that we're very near the stage where we can actually, I think, convincingly, because it's based on a large, really, representative sample of EEGs, all kinds of ages and problems in this cohort. I think we're close to the point where we can actually confidently say, detecting seizures and IIC patterns can be done as well as a person would do it, which is nice for these kinds of studies, right? It'll enable us to not have to spend hours and hours and hours, weeks and months on the labeling task and do the more interesting scientific work. So that's one thing. And then I think the other nice thing is that, as Sahar just showed, that we're able to start to go a little bit beyond this phenomenology and understand better, how much it matters whether these things happen or not. And I think there's a lot of unanswered questions there, actually, and which I'll talk about a little bit in a moment. But it's although it is clear that in the past couple decades we were missing a lot of these seizures and things. It's not clear whether that now, by knowing about them, we're always doing well, right by the patient. We may be. I think there's a lot of questions to be answered about how much, not just how much these things hurt the brain, but how much we hurt the patient by trying to suppress them, right? There's a risk-benefit balance that needs to be worked out kind of very carefully. And then, so I'll just, right now we're in the process of starting to, we're finishing up creating this model. We're not quite where we want it to be in terms of performance, but we're, nevertheless in parallel with that work, working on how to make this able to be deployed in real time inside the hospital. And then I'll just say a few words about the drug issue. So this risk-benefit balance with, so actually, if I go back to Sahar, this picture, we maybe swept it under the rug a little bit. That what we've kind of addressed so far is, the outcomes in relation to severity of injury, and then the effects of these IIC patterns. We so far have not fully figured out how to handle, accounting for the types and aggressiveness of the interventions we give. And the reason is that this is actually a fairly tricky issue. There's a lot of, what you do with the drugs depends on what you see on the EEG, and what you see on the EEG depends on what you do with the drugs. There's this feedback loop that you have to disentangle to really make sense of this. So I'll just mention two things that we've done so far, but there's a lot more work to do. So one is some of you may know there's some literature now about whether, at least in the seizure area, whether burst suppression is the best thing to do for non-convulsive status epilepticus, or instead seizure suppression, or maybe don't do anything, or do something very mild. There's also a similar kind of discussion in the critical care literature outside of seizures, whether burst suppression, when you see this on the EEG, is it something that causes harm to patients? So, and again, this is a causal question in the end. So one little piece of work that we've recently done that I think may end up being relevant for the seizure and status epilepticus question is, just when we see burst suppression that's inadvertent on the EEG, does it increase mortality? And I won't walk through this whole figure, but what we found was that burst suppression does seem to be associated with a bit of increased mortality, but the main cause of burst suppression is actually medical illness or frailty, right? And so this is similar kind of findings are surfacing now in the anesthesiology literature, where they're trying to see how best to manage patients on getting general anesthetics. The other angle that I'll just briefly mention, this is ongoing work, but so we've been working with quite a few different colleagues on this. Right here's a spectrogram. This is a patient who has a seizure right here, and you can see our automated annotations down here. This is the detector that we just went through. Red means a seizure is occurring, and you can kind of see what it corresponds to up here. We're showing down here the drugs, and you can see that what's happening with the seizures, it seems to be related to what's going on with the propofol. So this patient propofol was turned off briefly, a seizure occurred, probably as a result of that, and then the propofol was turned back on and the seizure went away. Actually, around the same time, lorazepam was given, so maybe the propofol or the lorazepam, or probably both, helped make the seizure stop. And so we're in the process. Here's actually one more example where this patient is having status epilepticus. You can see in the spectrogram, all these red things are seizures, and you can see there's some attempts here. There's lacosamide is being given down here. This little blip is a lacosamide dose and a phosphonated dose. You can see it's making very little difference. Over here, I don't see it. Actually, pentobarbital, a dose of pentobarbital is given, actually, and that seems to have an effect. So anyway, we're in the process of trying to disentangle this. And again, there's sort of several levels of complexity. There's there's various medications with different time courses, different levels of efficacy, and then there's also the feedback relationship between the EEG and the medications that needs to be. We need methods for handling that. Maybe I'll just stop with some just thoughts on zooming back out, from the details. Why automate all this stuff? Why not just keep on with what we're doing? Just reading EEG clinically. And so I think the benefits, if we can automate, a lot of EEG reading, will be reliability will go up, meaning same data in, definitely the same answer out. Unlike when we give things to humans and they may give different answers at different times. Speed, we have problems with being fast enough when there's a lot of patients, and so this will help. And I think maybe more important than this, I don't think we're at anywhere near having computers replace the need for experts in interpreting brain monitoring data, but there are a lot of places that don't have any experts, and so the ability to do remote EEG monitoring, increasing the accessibility of EEG to patients outside of the reach of specialized centers is one benefit of automation. And then finally, I think we started to show here, you got a hint where we can increase the utility of EEG by using automation or automated learning methods to see beyond what we can, the patterns, and kind of learn models that predict what they mean, like predict the outcomes, and hopefully eventually to predict what the best, or give us guidance about the best intervention. And I think, although this is maybe not as obvious, if we can do a lot of these things automatically, the cost should eventually go down. It should be much more scalable, and we should be able to reach more patients who need monitoring. I think the final, or actually, I guess I have two more slides. So there is some danger here, I guess. So there's a lot of excitement about what we're calling AI or automation, or people are now calling it AI in order to hype it. And there's a hype cycle, right? This that most new technologies follow, and AI is maybe not at all an exception, where maybe there's a lot of not very good quality results published, right? Because it's easier to publish than usual, and then eventually people get disillusioned when those things don't kind of live up to the promises made, and this can hurt the opportunities for things that actually do work to get out to patients and actually help them. So how do you avoid these kinds of problems with overhyping things? So I guess anyway, some lessons that I think we're trying to live by or learning from in our work is in the process of automating EEG interpretations, it's important to use what we call big data, and the data should be clinical, meaning we want the samples to really be representative. And in our case, ICU EEG monitoring, that's a huge basket, right? There's a lot of diseases, there's lots of ages, there's different levels of severity. So the data set that you need to use to train an algorithm and to demonstrate its performance on has to be quite large in order to be convincing that it's generalizable. We also need, it's common, I didn't really show you this, but it's common in the medical literature where these things are tried to test the model on the same data that was used to train it. So that's a not rigorous way of validating. You need to have independent test sets or do cross-validation, for example. And then the test sets need to be representative, just like the training data. When the source of labels is experts or people reading charts or something, the labels, the outcomes can be noisy. And so it's helpful to have lots of them in order to average out the noise, either from uncertainty or from, idiosyncratic, approaches to reading the EEGs of different experts. You don't want to fit to one expert's sort of preferences. You want to take advantage of wisdom of the crowd. And then the final thing is it's important to not just approach this as an engineer or just as a physician. It's important to have both domain knowledge and technical expertise to solve these problems in a way that is very meaningful. So I guess we'll stop there. There's a lot of different people, probably not all are even listed on this slide, who've contributed to all the work that we just talked about. So, but we'll be happy to take any questions now. So we'll stop there. Thanks.
Brandon, Sahar, thank you so much. That was wonderful. And if you could just click the Q&A tab, you'll see some questions there.
So let's see. So regarding signal analysis of complex EEG data, could techniques be borrowed from voice recognition to recognize events? Is an event analogous to a spoken word? Yeah, that's a great question. I guess I'll try to answer this one. So the answer is yes. So there's a couple of techniques that are kind of relevant. One is just the idea. So nowadays, speech recognition is largely done by recurrent neural networks, or combination of it's done by deep neural networks. And there's kind of two main types that are relevant. One is this convolutional neural network, which is what we're using right now. So that's a way of learning what features are useful to extract for a short segment of the data. That actually, I think that's going to get us very far for this, actually, as opposed to using handcrafted features. We have enough data to do that. But it's likely that in the end, to capture the temporal dependencies, or like for seizures, sometimes that's very relevant. And we'll use another technique that's very useful in speech, which is recurrent neural networks. And you can usually plug those things together. So the answer is yes, there's a lot of relevant stuff in speech. Let's see. Oh, and then I see Craig Maddox has said, you've come a long way since the flying pig. So yeah, that's awesome. It's fun to hear from Craig. That embedding map that we have now that I showed you is so when we first did this, we had some help from some people from Craig's team. It was fantastic. They came out and spent a couple of days with us, and we were able to get this kind of parallel distributed computing infrastructure set up, and we created the first map we ever created was for 7 patients, and it turned out it looked just like a pig, a flying pig, and so we have that still hanging up on our wall in the lab here. Sahar, do you want to take some of the other questions here?
Hey, Brandon, if you could not share your screen, we could see you.
Oh, okay. Sorry.
There you are. Look at that.
Here we go.
Thanks.
Sure. So let's see, maybe this one from John Baxter. Do you want to talk about this one, Sahar?
Could an AI system also recognize and incorporate significant interventions from the patient chart? I think that's the next question, right? Yeah, hang on, let me make sure I close my screen. So yes, and I think that's part of what we're working on as well is, there's automated ways to mark and annotate the EEG, but we're also using a similar method to extract data from the EMR, or we now have Epic, but we can do that for other electronic medical record systems as well, and sort of integrate all the information together. So that's part of that. I think we've already done quite a bit of that, but that's sort of the next steps in this research.
Yeah. Let's see. Let's see. I think there's some more comments down here. So here's one regarding signal analysis of complex EEG data. Could techniques be? Oh no, sorry, I already did that one. Let's see. Oops, I need to listen. Oh, okay, sorry. CNS envision hospital database, big data analysis of large trends with. Sorry, I'm not sure what that question is. Let's go lower. Are these data available to us? For the characteristic map, what is the X and Y axis? Is PCA the main tool? Okay, so let me answer those. So the data, some subset of the data actually will be available. We're going to hold some back for. So one of our goals is going to be able to have a set of data that can be used to test other algorithms. So we'll keep some of the data always hidden as a test set for any, for our own algorithms, but also for anyone else who wants to sort of validate it against a very, large set. So, but some of the data we will make available through a portal that we're currently creating. And actually some of the colleagues, if you're part of the CCMRC, are seeing the first versions of that portal where we're doing this annotation task. So yeah, some of the data will be available. And then the technical question about on the X and on the map, what does X and Y mean? So actually first, is it PCA? No, it's not PCA. PCA is a kind of embedding technique where you could just take the first two components that kind of explain most of the variation in the data. And then you get some kind of 2D map. That turns out to be a there's things that are much better than that now for looking at similarity, in feature space. And so the one that we use is we use one called TSNE, T-stochastic neighbor embedding. If you want to read about that, TSNE. And then the thing that we prefer lately is called UMAP. I think it's called Universal. I forget what it stands for, but UMAP, which is more scalable and tends to produce better maps. But the difference between that and PCA is that these embedding techniques, they really focus on whether patterns are similar or not. And so they tend to put things that have similar features close together and ones that have dissimilar features farther apart. Whereas PCA does something a little more crude. It's just like looks at their magnitude, the magnitude of components. And then there's a question here about how artifacts are dealt with before automated evaluation. So I'll answer this, and then Sahar, you can do, looks like one from An Ouyang. So the artifacts, so interestingly, yeah, this is a good question. We thought we wouldn't need to worry about artifacts because the neural networks are going to be so smart. They could just learn to see beyond the noise because we're not removing the artifacts when we're showing these examples to humans. It turns out that probably the last few little bit of extra performance that we need, we currently think that that's going to be kind of 80% fixing artifacts and maybe 20% getting a few more labels from experts. So from particularly hard cases. So we just this week actually we've had this exciting kind of breakthrough, and we have a new method for getting for essentially removing artifacts in such a way that the tricky artifacts hopefully won't trick the algorithm anymore. So there are some falls when you have hours and hours and hours of EEG. There's just so many chances for the artifacts to kind of like if you look at the sky for long enough, you're going to get some things that look like ships or pigs or kind of anything. With you given enough time, you're going to have artifacts that can fool the detector, and we're learning how to get rid of those. So I think that will be important. But in the results I showed you, we didn't do anything to remove the artifacts actually. Do you want to try the?
Yeah. So to answer the next question, in predicting outcome is only was it just EEG analysis or was other information used as well? So we did include prior medical history, basic demographics such as age, gender. We included disease severity scores such as the Apache 2 score, their GCS. We did not. So we included all the baseline clinical variables that we are known to be associated or predict for outcomes. So the Apache score, their age, the severity of illness, whether they had a brain injury, whether they had hypoxic ischemic injury, whether they had sepsis. We didn't include drugs in our model, and that's sort of what Brandon was talking about, which is part of our next step. In this model, we sort of, due to the confounding by indication and the fact that drugs are often given in response to the EEG patterns, we left them out. As we consider them to be as a part of the causal pathway between these patterns and outcomes. But we are working now on trying to really understand how drugs impact EEG. Because of the complex relationship, one, it's not just one drug. Usually these patients receive multiple anti-epileptic drugs, plus they're on anesthetics, propofol, midazolam. And so we're really trying to disentangle the individual effects of each one of these drugs and trying to come up with ways to analyze the combined effect of all these medications. So that is coming soon.
Yeah. Cool. Let's see. There was another question about, I think, how we, so from Gagan Narula says I think the question is asking how the experts did their labeling. And so the answer is, yeah, so when the experts do their labeling, we use essentially a version of the GUI that I showed you. It's a web-based version. Actually, I showed you a picture of it briefly. So we have the embedding map up there. We have the 4 spectrograms. Those are there to provide context. So you can, in the little application, you can change whether you're seeing like 5 minutes or 20 minutes or an hour worth of context. So that helps you when you just see the raw EEG on the screen and it's just 10 or 15 seconds, you can see, is that part of something that's evolving and more likely to be a seizure, or something that's static and maybe more likely to be, deserve the designation of GPDs or something like that. So they see all that. And then the users can also, the GUI is set up so that you can pan and zoom plus or minus a minute, so you can see, the context in the raw EEG as well. You can change montages and you can change gain. So it's a fairly decent, EEG viewer. Yeah. Now the model at the moment does not. We've tried to keep it fairly simple, so it only looks at the 15 seconds. One of the things we've played with is just giving it more context, like giving it the spectrogram as well, and other features. This is also the issue that I mentioned earlier with recurrent neural networks, trying to give it a little more, context in making its decisions. Will that will probably ultimately be necessary to get all the way to human level performance. And then, are we planning to use our weaning paradigm? I think in this paper that was published from, this is from some other colleagues that we work with, Dan Rubin and Eric Rosenthal. It would be nice to connect this eventually to that, but the features that are used in that are network, kind of connectivity types of measures, and we have not yet looked carefully at sort of how those relate to the features that we are using. The neural network is able to extract, at least implicitly, some features that relate to the correlation or what's called the connectivity between what's going on in different channels. So it may be doing something very similar, but actually understanding exactly how the neural network is doing what it's doing is kind of it will be an important issue that we're going to save for last. Right now we're just focused on performance, but it is true that it's nice to understand how it works, and it may be related to network issues in some ways. Yeah. Oh, and then Dongmei Chun says she is interested in, I think, participating in labeling data with our group. So just email me. We would love to have you join that. I think we might have. I think we might have covered all the questions, Dick. Can't tell for sure. Any other things?
That seems like it. And I know one of the questions was, will this recording be available? And the answer is yes. All of our webinars are recorded, and they usually are available within a week on our website. So this one will be up there. And Brandon, Safar, I want to thank you very much for taking your time today. And we made it through our first live webinar with very few problems. So thank you.
Thanks.
And it's good to see you're all safe and sound up there. And I can't wait to travel again and get up to see you guys. So take care. And thanks to all of our listeners. We had almost a record group for this one. So it's definitely a topic of high interest. And again, thanks for doing this.
Thanks. Pleasure.
Thank
Bye.
you. Bye-bye. Thanks.